Good morning, everyone. Welcome to Grand Rounds. It's my great pleasure this morning to introduce our presenter, Dr. Siddharth Singh. Dr. Singh attended medical school at the All India Institute of Medical Sciences in New Delhi, India. He then completed his junior residency in the Department of Laboratory Medicine, also at the All India Institute of Medical Sciences, followed by a postdoctoral scholar year at the Membrane Biology Lab of George Sachs at UCLA and the VA Greater Los Angeles. He then completed an internship and residency in internal medicine at the University of Iowa Hospitals and Clinics, followed by a fellowship in gastroenterology and hepatology at the Mayo Clinic in Rochester, Minnesota. He completed an advanced fellowship through the Maxine and Jack Zero Family Foundation Fellow in Inflammatory Bowel Disease at Mayo, and also completed a master's in clinical and translational science at the Center for Clinical and Translational Science at the Mayo Clinic, and finally, a clinical informatics fellowship in the Division of Biomedical Informatics here at UC San Diego. Dr. Singh is a leader in research in inflammatory bowel disease. He has published hundreds of peer-reviewed articles and has extensive grant support. We're really fortunate that he currently serves as an assistant professor of medicine in the Division of Gastroenterology, as well as an adjunct assistant professor of medicine in the Division of Biomedical Informatics, and an adjunct assistant professor of medicine in the Division of Geriatrics and Gerontology. Dr. Singh will be speaking to us today on population health management and inflammatory bowel diseases. Thank you so much, Dr. Singh.
Thank you so much, Dr. Jassel. It is my pleasure, and I thank you for giving me this opportunity. Good morning, everybody. Today, I'll be talking about one aspect of my research, which focuses on population health management in IBD. I'll highlight the work of some of our trainees here and go through how do we think about this important disease and the corresponding clinical and financial risk that it poses. These are my conflicts. And briefly talking about how I got into this, as Dr. Jassel was introducing, I was always interested in the science aspects when it pertains to medicine, and I initially tried my hands at basic science and translational research to figure out if that is something that is of interest to me. We know that the traditional phenomena of translational research goes from T0 to T2, starting from bench research, going into translational studies in humans and moving into clinical trials. I figured through my experiences that I'm probably not well suited for any of these. So I started exploring what are the other avenues, and that's where I realized the next aspect of translation, which is T3 and T4. How do we translate whatever we have learned on the bench through clinical trials into actual clinical practice? And that's where my master's degree came in. I decided to focus on the aspects of comparative effectiveness research in IBD. We had a lot of medications that have been approved, mostly through placebo-controlled trials, but to a patient sitting in front of me, the question wasn't whether the medication is effective, but rather which of these medications should I choose? This progressively evolved into concepts of guideline development, how do we translate it into value-based care, and now moving to aspects of population-level outcomes research or population health management in IBD. So I encourage each and every one of you to explore which aspect of research interests you and excites you. All of these are key and critical to improving the health of our community. In this talk, I will give a brief overview of what inflammatory bowel diseases are, what their burden is, and the variability of care that we've seen in our patients. And then we'll go into the core concepts of population health management, aspects related to risk stratification and predictive modeling, chronic care models for improving healthcare delivery, as well as how do we track performance and measure our metrics to see how well we are doing and how it eventually translates into better outcomes for our patients. So just as a brief background, what are inflammatory bowel diseases? Again, two main flavors. One of them is Crohn's disease. Historically, Crohn's disease is something that can involve anywhere from the mouth to the bottom, typically patchy disease and typically deeper level of inflammation. three main phenotypes. One of them is the inflammatory phenotype, which generally results in luminal narrowing and symptoms associated with abdominal pain, diarrhea, weight loss. And of course, if untreated, inflammation can progress to what we call fibrostenotic disease, wherein the inflammation is primarily replaced by scar tissue, causing strictures and obstructive symptoms. In a subset of patients, the disease can progress to deeper levels of inflammation going through the mural layers, causing fistulizing disease, either internally from bowel to bowel, or from bowel to other aspects and other organs, including the skin, bladder, and the perianal region. When we do endoscopies on these patients, we typically see deep ulcers, stellate ulcers, or rake ulcers, typically in a patchy manner. The Crohn's disease typically affects about 1 in 300 Americans. The other flavor of inflammatory bowel disease is ulcerative colitis, which in contrast to Crohn's disease will start in the rectum and involve variable degrees in a continuous manner, aspects of the colon. When we do endoscopies on these patients, they typically have continuous inflammation that is superficial, and I would typically describe it to patients as if somebody rubbed sandpaper through their colon. Patients are typically presenting with symptoms of bleeding, urgency, constant feeling of incomplete evacuation, but at the same time ending up at the bathroom multiple times. I'm sure all of you have seen these patients in the inpatient service and can relate to how aspects of healthcare, how their disease can impact various aspects of healthcare, both from their quality of life, their psychological health, as well as the financial risk that it affords to patients. Again, these are chronic autoimmune diseases for which we don't have a cure. So all our treatment is directed towards controlling symptoms, controlling their disease so that it doesn't disrupt their day-to-day quality of life, minimizes the risk of complications, and eventually most patients with IBD will have a normal course of life without an early mortality. The incidence and prevalence of IBD is rising globally. This was a synthesis of close to 160 population-based studies wherein patients had been seen or their incidence had been described in at least 3 different time points in these population-based studies. And as we can see, over the last 5 decades, the incidence of IBD has been rising globally. Because it is a chronic disease without cure, corresponding prevalence of the disease is also rising. We now think that finally the incidence of the disease may be plateauing in the Western countries, but the rates of rise or the incidence is rising rapidly in some of the newly industrialized countries, places like India, Hong Kong, China, Brazil. And the analogy that I use for patients is typically it's the urban areas within these countries that get affected by the disease first. Everywhere a McDonald's goes, 10 years later, the disease follows. So clearly our diet is playing a part in how the disease is spreading throughout the world. So diet and lifestyle measures are probably contributing to causing the disease. But once the disease gets out of hand, it's unclear what role ongoing diet has to play, and we have to rely on medications to control the disease. In the same synthesis of 160 population-based studies, roughly 75% of studies suggested that there's an increasing incidence in their populations. None of the population-based cohorts suggested a decrease in the incidence of the disease over a period of time. So this is something that we expect will continue to increase. We expect that by 2030, roughly 1% of the population, at least in Western countries, will be affected by inflammatory bowel diseases. Roughly 1/3 of these patients will be older patients, not necessarily because they have new onset of disease at an older age, but probably because our population is aging. And so some of these younger generations are getting older. And so we'll be dealing with a lot of these patients even at an older age. Since the time that I started my fellowship back in 2011, the number of therapies and the number of treatments that we've had for IBD has progressively expanded. When I started fellowship, anti-TNF agents were the primary biologic agents with excellent results. I can only imagine for people who were doing the prime part of their training back in the 1990s, dealing with corticosteroids and thiopurines as the primary source of treatment for this. And definitely the introduction of anti-TNF agents was a whole change. However, we now recognize there are multiple different mechanisms of action that can be effective in the treatment of IBD, and questions related to positioning of these therapies in the context of their relative efficacy and safety, and in the context of patients' values and preferences and risk of disease and treatment complications are important. Now we have close to 4 different biologics, 4 different mechanisms of action which have been approved for ulcerative colitis and Crohn's disease, and there are multiple others that are in advanced phases of development. And all of these treatment advances have resulted in improvement in patient outcomes. This was work that Lester led, looking at a systematic review and meta-analysis of close to 45 population-based studies evaluating the risk of surgery over time. And if we look at cohorts that were recruited primarily before 2000, we generally think that a 5-year risk of surgery in patients with ulcerative colitis is close to 10%, and the corresponding risk in Crohn's disease patients is close to 36%. In fact, during my training, one of my mentors said, if a patient with Crohn's disease hasn't had surgery, you should question their diagnosis because Crohn's disease invariably over 20 years of diagnosis will result in surgery in 3/4 of the patients. However, with advancements in how we are diagnosing these patients, treating them early, advancements in the medications, we have noticed a progressive decline in the risk of surgery by about 30 to 50%. Now, as opposed to 20 years ago, the 5-year risk of surgery in a patient with ulcerative colitis is closer to 7%, and the corresponding risk in patients with Crohn's disease is closer to 18%. So roughly a 50% decline over the last 2 decades. And it's all a result of improvement in the diagnosis, how we approach these patients, improvement in therapeutics. However, at the same time, the cost of IBD care has progressively increased. This was work that was led by Nia Nguyen, a former resident of the Department of Internal Medicine, now a graduating GI fellow pursuing a fellowship in clinical informatics and IBD. And you'll see throughout the talk, he's done a lot of this work in this area. Alex is the other person. He's currently getting into the 4th year of medical school. Unfortunately, we couldn't keep him excited enough in GI, and he's going to go into radiation oncology, but he definitely has a lot of interest and expertise in aspects of population health management and how to analyze big data. In this study, we combined 2 publicly available data sources, the Global Burden of Diseases study, as well as the Disease Expenditure Project, and looked at the cost and prevalence of IBD in the United States. These 2 graphs represent the prevalence of IBD in different age groups. And as we can see, the prevalence of the disease is progressively rising in these lines, but at a higher rate, the cost of IBD care is rising in these patient population. The bar graphs represent the expenditure associated with the disease, and the colors represent the age group. Across age groups, the younger as well as older population, the cost of IBD care has progressively increased from about $6.4 billion in 1996 to about $25.4 billion in 2016, after accounting for inflation. And per patient spending on IBD has increased from $5,700 to close to $14,000. And if you look at how we are spending this money when managing patients with IBD, this was from the same Global Burden of Diseases and the Disease Expenditure Project. The bulk of the cost of healthcare costs related to IBD are still attributable to inpatient and emergency department care, or what I would refer to as unplanned healthcare utilization. Ambulatory care accounts for about 21% of costs. The cost of pharmaceuticals is progressively increasing in this disease as we are dealing with more and more biologics, which are expensive medications, and they currently account for about 20% of costs in the United States. In other countries where there's a more socialized medicine, the cost related to inpatient care may not be as high, and biologics are progressively increasing in terms of costs associated with the disease. We frequently hear from our population health management team about the expensive medications that we are using, and we're frequently in discussions as to how we can optimize the use of these medications while improving outcomes for our patients. Let me focus on aspects of unplanned healthcare utilization. This was work that Nia did while he was still a medicine resident, looking at the burden of the annual burden of hospitalization in patients with IBD using the nationwide readmissions database. So this database is able to longitudinally track patients over the course of 1 year from one hospital to the next. We transformed this. It was primarily designed to look at 30 or 90-day risk of readmission, but we transformed this into a longitudinal cohort wherein each patient was followed for the course of 1 year. We looked at patients who were hospitalized in the first 6 months to see what is the rate of annual burden of hospitalization in these patients. And as we see, overall, a patient with IBD who is hospitalized would spend about 0.6 days per month, or an average about 5 days a year in the hospital. and monthly costs are close to $1,300. 30-day risk of readmission is closer to 18% for our patients with IBD. However, there is a small subset of high need, high cost patients who spend exceeding amounts of time in the hospital. Typically, these patients are in the top 10, the top decile of healthcare utilization or days spent in the hospital, are spending close to 4 days a month in the hospital. I'm sure you're familiar with these patients because you've been involved in caring of these patients, and you'll see there are what we call frequent flyers that we see in the hospital. On average, these high need, high cost patients are spending close to $7,500 every month for hospital stays. They're typically hospitalized once every 2 months. And this top 10% typically account for close to 40% of hospitalization costs. And if you look at the top 2 deciles, they're accounting for close to 60% of all hospitalization costs that we're seeing in our patients with IBD. So what determines why is there so much variability in healthcare utilization in IBD? And I'll break this down into 3 main domains. This was work that I did with Paramveer Dulai, who's a gastroenterologist and IBD specialist, and a colleague here who's also focused in population health management. And there are 3 main domains that we can figure out as to why there may be variability in healthcare utilization. Social determinants of health, disease determinants of health, and treatment determinants. And I'll go into each one of them individually. Looking at social determinants of variability in healthcare utilization, clearly patients with lower access to healthcare, where care is more costly and the resources may not exist, are significantly more likely to have limited access to outpatient care and are frequently seen in inpatient care because of lack of continuity of care. In this study, again led by NIA, using a publicly available database, which was a National Health Interview Survey, we identified that roughly 1 in 4 patients with IBD report financial hardship due to medical bills, and roughly 1 in 7 patients are unable to afford to pay these medical bills. Roughly 1 in 6 report cost-related non-adherence to medications, and this translates into cost-reducing behaviors, limited compliance with medications, and you can see how this will translate into variability, into higher rates of unplanned healthcare utilization. 1 in 7 patients with IBD report food insecurity, and 2 out of 3 patients report personal and financial distress. All of these factors eventually translate into higher rates of emergency department visits. And unfortunately, these different aspects of social determinants of health are not independent of each other, but rather there is a significant overlap. In this figure, if you look at how the distribution of these different risk factors are corresponding to their ability to pay these medical bills, patients who are unable to pay medical bills at all, roughly 30% of these have associated cost-related non-adherence to medications, personal and financial distress, and food insecurity. So this is again a subset of populations that we need to focus on in order to improve the population health, improve patient outcomes, as well as population level outcomes. Going into disease determinants of variability in healthcare utilization, again, all of us are attuned to thinking about disease severity as it pertains to outcomes for individual patients. And there are different scoring indices or different risk factors that have been identified, which suggest a more severe prognosis. For Crohn's disease, those things involve extensive anatomical involvement, perianal or rectal disease, deep ulcers and endoscopy, prior surgery, and again, like I previously mentioned, strictures and a penetrating behavior. For ulcerative colitis, that again involves a younger age, a requirement for corticosteroids, deep ulcers, extensive disease, prior hospitalization, C. diff infection, as well as CMV infection. So all of these are individual prognostic factors for a specific patient, but they don't necessarily determine the variability in healthcare utilization or don't necessarily inform healthcare utilization risk for these patients. And that's where we need to think about broadly what are the different factors that can influence the risk of unplanned healthcare utilization, not just the risk of disease-related complications. One of the aspects that becomes very relevant that is highlighted here is the impact of psychiatric comorbidities on healthcare utilization. And this has been consistently borne in multiple studies. This was work that was led by Eddie and Nia, looking at the impact of psychiatric comorbidities on risk of total days spent in the hospital, risk of readmission, and risk of severe IBD-related hospitalization. and what we consistently observed that the presence of psychiatric comorbidities was associated with higher rates of 30-day readmission, severe IBD-related hospitalization. And this has been demonstrated in multiple other studies. The University of Michigan group tried to define and come up with a risk prediction model for predictors of high-cost patients, or patients that they defined had IBD-related treatment charges in excess of $30,000 per year. And here again, certain treatment determinants like the use of corticosteroids and narcotics, as well as the presence of a psychiatric illness and high burden of inflammation were associated with were predictors of high-cost patients in their population. And this probably holds true across the board if we were still to start looking at other populations. Finally, looking at aspects of treatment determinants of variability in healthcare utilization. This is just a representative Sankey diagram as to how patients flow once they start treatment using a large database led by Corey Siegel, close to 16,000 patients diagnosed with Crohn's disease. And what they observed is 42% of patients were treated with corticosteroids as their main therapy first up, and 35% were treated with aminosalicylates, and less than 0.5% were on biologics as the first-line treatment. Think about this in the context of what do current guidelines recommend. For moderate to severe Crohn's disease, main society guidelines, the AGA recommends against the use of corticosteroids for maintenance of remission. They're good agents for induction of remission, but they're not maintenance regimens considering the side effects. And the AGA also recommends against the use of 5-aminosalicylates or sulfasalazine over no treatment. Both of these were strong recommendations with moderate certainty and evidence. Yet, when we see how we are practicing, we see that among patients who start corticosteroids, 63% of them continue to receive multiple courses of corticosteroids. And it took about roughly 1.5 to 2 years before they got on more effective biologic therapies or immune suppressive therapies that actually have been demonstrated to change the natural history of the disease. So clearly how we are translating guidelines into clinical practice is a big lacuna and a place where a gap needs to be filled. Other aspects of treatment determinants are fragmentation of care. This was a study again led by the Michigan group using the veterans database. Close to 20,000 veterans with IBD over a 13-year time period. And they defined fragmentation of care based on this Bayes-Boxerman continuity of care index, which measures the density and dispersion of care. How many different providers is a patient seeing? The more the dispersion of care, the lower the continuity of care for these patients. Expectedly, for most patients with IBD, we expect this index, which generally ranges between 0 to 1, to be at 0.5. We expect IBD patients to have one primary care doctor and one gastroenterologist. However, when they looked at this, there was clearly widespread variability in dispersion of IBD care. And what this eventually translated is a lower continuity of care in the first year of their visit in the VA system was associated with a higher risk of hospitalization and surgery in subsequent years. So if there's lack of outpatient continuity of care, it will result in higher rates of hospitalization and adverse outcomes for our patients with IBD. Again, there is intrinsic confounding by severity in the sense the patients who are more severe are more likely to be seeing more different specialists, but they accounted for this in their multivariable analysis. We did a similar study looking at fragmentation of care for hospitalized patients and observed that patients with roughly about a quarter of patients with IBD who are initially admitted to one hospital will be readmitted to a different hospital on follow-up. And when we look at patients with multiply fragmented care who move from one hospital to the next to the third hospital, the patients with this multiple fragmentation of care had higher rates of unplanned healthcare utilization moving forward. So that's another aspect which contributes to unplanned healthcare utilization that needs to be addressed, that falls within the purview of population health management. So summarizing this first part of the talk, I informed you that the incidence and prevalence of IBD is rising globally. It is an expensive condition, and while the cost of medications is increasing in the United States, unplanned healthcare utilization still accounts for a majority of the costs associated with the disease. And this may be attributed to a considerable variability in the burden and patterns of healthcare utilization, with disease determinants, treatment determinants, and social factors being the key drivers. In the next part of my talk, I'll talk about certain strategies for risk stratifying these patients, preventing complications to improve the quality of care and reduce costs associated with IBD. So moving on to the segment of what exactly do we mean by population health management? And if you talk to a wide variety of people, there is no single definition of population health management. Yet it is one of those buzzwords over the last 5 to 7 years that we've seen frequently pop up in Google searches. The insurance companies, a lot of different people are looking at what population health management would be. In general, population health management, conceptually speaking, refers to coordination of care at a macro level to improve outcomes and effectively manage the clinical and financial risk for a defined group of individuals. So you're now moving away from the care of an individual patient, but rather to this panel of patients that you're caring for. CMS suggests that population health management involves both a clinical perspective focusing on delivery of care to groups enrolled in a health system, as well as a broader perspective that focuses on the health of all people in a given geographic area and emphasizes multi-sector approaches and incorporation of non-clinical intervention to address social determinants of health to eventually improve outcomes at a population level. The triple aim of population health management is to improve quality of care, population level outcomes, and reduce healthcare costs. So what are the steps in population health management in IBD? And this is work that Dr. Durai, myself, Dr. Sandman, and Dr. Ona Machado led in trying to conceptualize the framework for population health management in IBD. I will go through this complex figure in the course of my subsequent slides, breaking it down into different steps in population health management. But broadly speaking, the 3 steps in population health management involve effective risk stratification so that we are able to identify our high-risk population as well as sources of variability in care, and that is these boxes here. The next part refers to chronic care models for management of these high-risk patients or these at-risk patients, and how do we integrate different clinical, non-clinical interventions, as well as to improve healthcare delivery for these patients. And finally, within the context of any such approach, how do we track our performance? How do we measure different quality metrics to see if we are actually making a difference? And this basically encompasses the goals of population health management, which are to promote most effective practices, reduce harm caused by delivery of care, promote effective communication, and ensure patients and providers are engaged in shared decision making. So let's talk about what we mean by risk stratification. And here again, distinct from risk stratification for an individual patient, you're talking about risk stratification for healthcare utilization for these patients. And that's a key tenet of population health management. Conceptually, patients with IBD can be divided into 3 groups. There are well patients, there are patients at risk for complications, and the patients who have already had complications. Patients can move back and forth between well population and being at risk, but the goal is to minimize the risk of progression to complications. The former group of patients are low utilizer, low cost of patients, where the focus is on prevention and preventing harm from our treatments, whereas these patients can readily translate into high utilizer, high cost patients, especially those patients at high risk for complications, and those patients will subsequently afford the need for stronger medications, hospitalizations, and surgery. 3 main sources of variability in the care of patients with IBD that can inform this risk stratification are: how do we manage acute flares of disease activity? How can we access these patients quickly? How can we put them on effective medications? And how can we translate them back from this box of being at high risk for complications back into a well patient, rather than progressing to a patients with complications who will translate into high utilizers and high cost patients? How do we prevent disease-related complications through long-term management? But at the same time, for the well patients, how do we minimize the risk of treatment-related risk for these patients? And the goal for population health management here would be to identify these triggers of transition and identify the subpopulations most likely to benefit from this coordination of care at shorter intervals to get them back into a well state rather than progressing to higher risk of complications. How do we identify patients at high risk for becoming high need, high cost? This was actually the work that was initially started through work that was done by Dominic looking at machine learning-based prediction models for diagnosis and prognosis of IBD. And what we identified is that most of those machine learning models have typically focused on how do we diagnose patients better, how do we prognosticate their response to specific medications, but they haven't necessarily focused on how do we identify patients at high risk of becoming high-need, high-cost patients. And this was subsequently carried forward by Nia, who actually developed a machine learning model together with Peter Chen in our cohort of patients within the nationwide readmissions database. And by going through close to 40,000 patients in NRD 2013 and validating it in a 2017 data set, there were 5 main variables that stood out: the length of stay at index hospitalization, comorbidity index, use of an operating room procedure at the index hospitalization, frailty risk score, and age of admission. And with these 5 variables using a machine learning model, we were able to distinguish the likelihood of becoming high-need, high-cost over the course of 1 year with an AUC of 0.78, outperforming the typical logistic regression model that we have historically used. However, it is important to note that this model was only based on hospitalized patients and does not account for what happens outside of the hospital. And this is work that Nia is now leading, both within Optum Labs, which is an administrative claims database, as well as the UC data warehouse, trying to identify what are baseline clinical factors prior to an index hospitalization, what happens during that particular hospitalization, more importantly, how does post-discharge management of these patients eventually modify and predict the risk of somebody becoming a high-need, high-cost patients, or how do we identify those frequent flyers that are high risk of unplanned healthcare utilization. Of course, both of these databases fortunately give us access to some insight into social determinants of health, and integrating all of these patient-level factors, hospital and hospital system, health system related factors with regard to post-discharge management, as well as social determinants of health. We hope to be able to improve upon our ability to identify these high-need, high-cost patients. Let's talk about what do we mean by a chronic care disease model for at-risk patients. This is something that is very pertinent to patients with IBD. And the concept of chronic care disease model is to shift from a current framework of ambulatory care, where it's more an acute episodic reactive encounters. The patient was advised to follow up in 6 months, and we don't know what happens between now until 6 months. These patients may start flaring up, and we just don't have an ability to get them into our clinic in a timely manner and treat them appropriately to avoid that hospitalization. We need to gradually move from this acute episodic reactive encounters to more proactive plan and develop an individualized long-term care. Perhaps that well baby check can happen at annual basis or can happen over telehealth, but at the same time, the patient who's at risk for complications needs a closer level of management, needs to be accommodated in the clinic quickly with a better level of care, or needs to be reach out with our a multidisciplinary team that can take effective care of this patient. A typical chronic care model is centered around co-production of care between patients and providers, and typically incorporates 6 main aspects. And I'll go through all of these, the 6 main aspects individually. The first 2 aspects pertain to self-management support and providing community resources. These are things that happen at a patient level. Our goal here is to have an informed, activated patient who's in charge of their health, rather than relying on the healthcare system to take care of them. The examples within this would involve counseling for self-management, written treatment plans, tailored education, skills training in cognitive symptom management, and now multiple mobile health applications to help patients track their symptoms, improve adherence to therapy, identify potential triggers for them. And of course, recognizing that there are clear disparities in how access to healthcare is limited across different populations, identifying services within the community to improve access to care, improve basic needs is important. Here, certain examples include developing social networks to provide peer support and share experiences with other patients. The next 2 aspects of chronic care models involve clinical information system and clinical decision support. Basically, how do we organize patient, provider, and population level data to facilitate timely, efficient, and effective care? And how do we utilize and incorporate best available scientific evidence that is sensitive to patients' values and preferences? And these involve proactive care planning for patients at highest risk, for complications, automated timely updates on patients' clinical status outside of the healthcare system or outside of those episodic encounters, as well as clinic point of care clinical decision support tools to minimize variability in care that happens at a provider level. And the last two components of chronic care delivery systems is a delivery system redesign and healthcare organization buy-in. How do we assure effective and efficient healthcare delivery suited to a patient's needs and create a collaborative culture focusing on high-value care? This may involve aspects of multidisciplinary team visits with multiple different providers that needs to be accessible depending on the specific patient's needs. How do we effectively utilize non-clinical staff? And as we've realized over the last 18 months, how does telehealth play a part and can play a significant part in remote monitoring and management of these patients? And from a healthcare organization standpoint, how do we incentivize quality improvement? I'll walk you through three main examples of chronic care models from an IBD perspective. We've been involved in some of these to help improve the care delivery for our patients. Just briefly talking about how it pertains to other diseases, a meta-synthesis of 27 reviews on integrated care strategies for diabetes, heart failure, asthma, and COPD identified that overall these chronic care models result in improvement in functional outcomes, adherence to guideline congruent care, decrease in unplanned healthcare utilization, and they may have a mortality benefit and improve clinical outcomes. But it's unclear at this point whether they're cost saving. And I think the problem here is the mismatch between the investor, which is the practice, and the beneficiary, which is the insurance. Initially, all of these chronic care models require a high investment to redesign this delivery system, and it takes time to materialize. Unfortunately, most of these models have looked at things over 1 to 2 years, and at that time, it's harder to assess that cost savings. Moving into certain examples for IBD, IBD Chorus is one example. This is a learning health system with close to 55 academic and community practices throughout the country. We were one of the initial sites that joined in 2016. And the core tenet of this is co-production of care, capturing patient-reported outcomes data at each visit, feeding forward physician and care team using a shared data platform, and using a variety of quality improvement methods to progressively improve quality of care that is delivered to patients, and usually involves a typical breakthrough series initiative for quality improvement, multiple PDSA cycles to improve outcomes. One of the first initiatives for IBD Chorus was this Urgent Care Breakthrough Series collaborative, in which 26 gastroenterology practices, including UCSD, over a 15-month time period, looked at more than 20,000 patient encounters. In a prospective manner, we identified primary and secondary drivers of change. What are the factors that result in unplanned healthcare utilization? What are the main goals of care that we're trying to address by improving the quality of care, minimizing unplanned healthcare utilization, and keeping the patient at the center of this? And with this, our team came up with a change package or a toolkit of interventions that all of these individual providers and teams at individual sites came up with. And there were 19 process changes that were identified to improve healthcare delivery. The ones that were implemented over the next 15 months by the vast majority of sites were simple things like maintaining a high-risk patient list, identify the patient that we think is going to be at high risk for complications, and this involved the aspect of the clinical information system from a chronic care model. Proactive communication with the high-risk patients, engaging our nurses, our nurse coordinators in improving access, educating patients about when and how to seek urgent care, and adding urgent care slots in the clinic for improving access. And over an 18-month time period, across the collaborative, we observed about a 22% relative decrease in emergency department utilization and roughly a 21% relative decrease in hospitalization for these patients over a period of time across these sites. Obviously, the more engaged sites had higher rates of these outcomes as compared to sites that were less engaged. A corresponding cost analysis demonstrated that all of these initiatives were not very cost intensive and were cost effective to the health system by decreasing unplanned healthcare utilization. My next example is a community-based IBD intensive medical home, which is Project Sonar. This is led by Larry Kozinski, who's a colleague, a private practice gastroenterologist, and who's now the CEO of Project Sonar, based on the success of this model translating into a company. Project Sonar is born out of a need that when Larry was looking at his individual practice in the Illinois gastroenterology group, what they identified is that roughly 2 out of 3 patients who were admitted to the hospital did not have a healthcare visit within the preceding 3 months. So clearly there were access issues for these patients. With our reactive encounters, we were not able to identify these high-risk patients. So what Larry came up with, and we helped them look through some of the data, was 4 components within this community practice-based medical home: a technology-enhanced patient engagement platform, EHR-embedded clinical decision support tools, using a risk assessment tool that determines the course taken, and circling it back with the claims data for these patients to analyze the impact of the program. So what that essentially involved is a collaboration between Blue Cross and Blue Shield of Illinois with Illinois Gastroenterology Group. Of course, now this is expanded to across BCBS, across multiple states. But what typically happens is patients are impaneled by the insurance. They get enrolled by a nurse coordinator into the Sonar platform. They complete what is called a super visit, where you're incorporating and assessing aspects of psychiatric comorbidities, social determinants of health, individual disease determinants of health, understanding patients' values and preferences. And once these patients are enrolled, every month they get a ping, which basically goes through 5 questions focusing on how their disease is doing. A nurse then manages and observes these pings and sees what proportion of patients, what is the change from their previous month's report. Roughly 16% of ping scores they identified in their initial cohort of patients fall out of traditional benchmarks. The nurse then reaches out to patients proactively and say, hey, I observed that there's been a change in your disease activity, you're experiencing more symptoms. It goes over some of those things, tries to identify if there's something readily remediable. And if not, reaches out to the patient's providers, who then brings the patients into the clinic, treats them appropriately based on this EHR embedded clinical decision support tools to inform standardization of care. With this, the low-risk patients are continuously monitored for any breakthroughs, and high-risk patients receive earlier interventions. And what they observed and what we observed by looking at these data is that this resulted in roughly a 50% decline in unplanned healthcare utilization, and rates were higher in the more engaged patients. So this was born out of a community practice, needs that are identified by a single provider, and now with the next 10 years has actually expanded into a much broader initiative. This has translated into an alternative payment model, wherein now Blue Cross Blue Shield actually panels patients and gives a per member, per patient cost back to cost savings that the Illinois Gastroenterology Groups has for its impaneled patients by preventing unplanned healthcare utilization. And finally, another aspect of an IBD specialty medical home is the Pittsburgh IBD Specialty Medical Home. This was again an academic practice-based specialty medical home led by Miguel Reguero. They identified that within their practice, 15% of patients accounted for roughly 50% of the costs. There were a subset of super utilizers, 32 patients that accounted for roughly 10 million of inpatient charges. And the thing that was common for these patients was aspects of chronic pain, stress, coping difficulties, and anxiety and depression. And so they came up with this outpatient medical home wherein a multidisciplinary team with a gastroenterologist at the center of this, patients at the center of it, gastroenterologists leading the coordination of some of these efforts, involving a social worker, a psychiatrist, a nurse who manages, who triages these patients, motivational coaches, schedulers who serve as motivational coaches, nurse practitioners serving as care managers. And their goal was any patient who is impaneled within this needs to get access within 72 hours, does not need to meet each and every member of the team, but specific to the patient's need, identify who's the team member most able to address the patient's needs, have a team visit with the patient initially, and subsequently after the patient visit, the team groups again to identify how we can best take care of the patient. And what they were able to observe is that about 350 patients that they paneled within the specialty medical home in the first year, there was roughly a 50% decrease in ER visits, 48% decrease in hospitalization, improvement in quality of life, and decrease in unplanned care. And there were significant cost savings to the health system, despite an increase in the specialty drug use costs. And in talking to Miguel, it's invariably well, it's infrequently the actual IBD-related inflammations that's responsible or that's driving this unplanned healthcare utilization. But a patient who's unable to cope with the disease, chronic pain patients, patients with anxiety and depression are the ones who are frequently seeking unplanned healthcare utilization. So the biggest component in talking to Miguel has been the psychiatrists and psychologists, as well as the pain specialists, who've been helpful in minimizing the patient's unplanned healthcare utilization and improving access. Looking through digital health technologies, we Nia recently, together with Ivan Martinez, who's a second-year resident at UC Davis, looked at what are the digital health technologies and how they have been used in IBD. And through a systematic review of randomized controlled trials involving different remote monitoring strategies, web-based portal, and mobile applications, what they've observed is that as compared to traditional health encounters, these digital health technologies do decrease unplanned healthcare utilization and healthcare costs. They may not have a significant impact on a specific patient's IBD disease activity or symptomatic relapse and IBD quality of life, but it definitely improves population health. Finally, moving on to the last step within this context is measuring performance and refining metrics as it pertains to population health management. Unfortunately, our current quality metrics for IBD are focused on what is readily measurable and largely focus on aspects of primary prevention, talking about smoking cessation, vaccinations, cancer surveillance, and for our inpatients, talking about venous thromboembolism prophylaxis and bone loss screening. They do not necessarily talk about what are the factors that may have a biggest impact in outcomes of our patients. And those are some aspects related to achieving mucosal healing. In the sense, it's not just focusing on whether or not patients' symptoms improve, but ensuring that there's actual improvement in the inflammation or the burden of inflammation that is seen. How do we optimize early use of biologics for the right patients, avoid biologics for patients where it's not going to be successful, and at the same time optimize the use of biologics with increasing the use of biosimilars, which afford cost savings to the health system. And this requires the use of innovative disease registries. Talking briefly about disease registries, credit to Amy Sirapati, who's leaders in designing registries and working with Nia and myself to help develop an IBD-based registries. These are slides from her that she was able to share what goes into a typical disease registry, identifying diagnosis, lab values, procedures, developing that risk score for a particular patient, and subsequently looking at rates of utilization. And what this involves is first translating back what that quality metric is that has been defined into a specific cohort, preparing it into a program agnostic cohort for to develop quality measures for a population health approach. Once this cohort is then translated into specific inclusion criteria, inclusion rules for a registry, looking at metrics, care teams, outreach and concepts within this, and organizing this within the EHR so that we are readily able to track these patients based on these important metrics. And then we develop an intervention at a population health level and measure the impact of that part in identifying some of the outliers and seeing how our interventions result in improvement in performance, system reliability, outcomes, and estimated financial impact of that intervention. So summarizing these concepts, in a final slide, we know that there's wide variability in healthcare utilization in IBD, as well as variability in the quality of care that is delivered. Population health management strategies aim to streamline the care of the majority of these patients, a concept that is called mass personalization of therapy, to identify the patients who are at high risk of unplanned healthcare utilization for early intervention, develop chronic care models which involve co-production of care, innovations in health IT platform and clinical decision support tools, redesigning how we deliver healthcare delivery, and partnering with investors and beneficiaries to overall decrease societal healthcare costs. And finally, refining and measuring metrics for high value care that reward appropriately or using appropriate metrics rather than things that are easy to measure. With that, I'll stop. I'd like to thank the entire IBD team, specifically highlighting Bill Sanborn, Paramveer, and Nia, who's led a lot of this work. Medicine residents who've been involved in leading some of these efforts, as well as others who've been involved in other projects. colleagues in biomedical informatics, Amy Sirpari, Lucilona Machado, Mike Hogarth, Jihoon, Paulina, and Gio, Parag Agnihotri is involved from a population health management perspective, as well as outside collaborators who've been helpful in developing these aspects and these concepts of population health management. With that, I'll stop, and I'll be happy to answer any questions.
Dr. Singh, thank you so much for that outstanding and inspirational presentation. I also just want to acknowledge what an incredible mentor Dr. Singh has been to our internal medicine residents interested in GI. We're really grateful to him, and I'm grateful to him for highlighting the work that they contributed to this presentation. Thank you, Dr. Singh.
Sure, thank you.
We have a question from Dr. Rubin, and he apologizes in advance that it's long. Is the focus on high-risk patients too late in the course of disease? Hygiene hypothesis with alterations in microbiome that occurs with societal dietary changes, coupled with genetics, may select at-risk patients in childhood. Or, for example, risk of IBD increases with increased C-sections that skews the neonatal microbiome. Proactive therapy may be directed at this age group.
That is a next level of population health management, Dr. Rubin. I fully agree that the paradigm needs to shift from treatment of established patients to actually prevention of disease. And that's a whole discussion related to lifestyle interventions, dietary interventions. That is probably something that needs to happen over the course of the next 20 to 30 years, less the disease, the rates at which it is rising, and the corresponding risk to these patients, and the financial risk that they afford to the healthcare system. It will have a significant impact on these patients. So I fully agree that prevention at a community level is the core concept of population health management and management of disease overall, and management of chronic diseases, and will have a significant impact across all chronic diseases, not just IBD. My focus was specifically on, once a patient gets diagnosed with IBD, identifying and minimizing their risk and improving population level outcomes for those patients. But I think there's clear synergy, focusing on, instead of this aspects of the spectrum, gradually shifting, and there's a whole bunch of literature and work that is going on related to those aspects.
As a primary care doctor, Dr. Singh, it strikes me that this type of model of upfront investment in the care of patients with complex chronic diseases could really be generalizable to so many different types of chronic diseases that result in high healthcare utilization. I think it's very, very inspiring, and hopefully we can learn some lessons from this work for some of our other chronic disease management.
No, I fully agree. I think these concepts lend themselves to a lot of chronic diseases, and there's a lot of work that is going on within the health system to try to improve our population level outcomes, as we are focusing on to value-based care and how do we improve our panel of patients for optimizing outcomes.
If there are any other questions, please type them in the Q&A box. If not, we're going to transition now to a special portion of today's Grand Rounds. It's my pleasure to introduce Dr. Elaine Muchmore. Dr. Muchmore was the UCSD Internal Medicine Residency Program Director for many years and has been an incredible role model and mentor to me. We're very fortunate to have her today to present our Resident Research Award. Thank you, Dr. Muchmore.
And thank you, Dr. Jassel. One of the wonderful traditions of the residency program has been, on the occasion of the last Grand Rounds of the academic year, to present the Resident Research Award. And I've got to say that every year that has become more difficult. Those of you who watch Grand Rounds regularly know that the 4 finalists this year were perhaps the best that we've ever had. But you may wonder why Dr. Jassel introduced me to give this award, because it is the program director's purview to make the announcement. This year, on the occasion of my retirement, 2 of our graduates gave $500 to the Department of Medicine, and we decided to make these awards, financial awards, to the finalists from this year. And so it gives me great, great pleasure. We see who the finalist is, Dr. Sampath Kumar, who I was so proud to listen to, really not just a great presentation, but something that I think will have an impact, even perhaps on clinical care, even perhaps before the prospective trial is published. So I'm very pleased to make this award to her. And our plan is to give the finalist, the winner, $200, and the other finalists $100 each. So congratulations.
Thank you so much, Dr. Muchmore. It's a true honor, and to even have a financial prize is just above and beyond, and can invest that into future research as well. So really thank you for the opportunity, and thank you to Dr. Jassel, the whole program, and to my mentor, Dr. Ben Yehuda, who really was so instrumental in all of this and is a huge supporter, and thank you to everyone.
Congratulations, Dr. Sampath Kumar, and I just want to thank Dr. Yushi and Dr. Will Collins for their generous gift in recognition of all of Dr. Muchmore's incredible contributions to resident and fellow education. I also want to take this moment to present an award to Dr. Muchmore. I'd like to present her with the Department of Medicine's Distinguished Service Award in recognition of her outstanding commitment to resident education and the many roles in which she has served during her illustrious tenure as a clinician and educator at UC San Diego and the VA San Diego. I know many of you know that she served not only as the Associate Vice Chair for Education for the Department of Medicine, as the Program Director for the Internal Medicine Residency Program, as the Program Director for the Hematology Oncology Fellowship Program, but also as the Associate Chief of Staff for Education at the VA for many, many years, and has mentored so many of our current faculty and so many future trainees. She also continues to serve on the National Resident Review Committee for the ACGME, and we have all just been so privileged to benefit from her continued and ongoing mentorship and guidance. Congratulations, Dr. Muchmore, and I will be giving you this award in person shortly. It was also announced at graduation, which was virtually presented to you this year.
Thank you so much. And thanks again to Yushi and Will Collins. I actually hope that we can make this a tradition with regarding to making a financial award to the research resident who wins the research resident finals.
Thank you so much to everyone for joining. Thank you, Dr. Muchmore. Thank you, Dr. Sampath Kumar. And thank you again, Dr. Singh, for an outstanding final presentation to our Department of Medicine Grand Rounds. We'll see all of you again in September when Grand Rounds resumes. Stay tuned for the announcements and information. For now, Grand Rounds will continue to be virtual via Zoom, but we'll keep you posted as soon as it's feasible to have it in person again. Thank you. Bye-bye.